Good morning, everybody. I'm going to call this meeting to order. Can I please have a roll call? Roll call there. Thank you. Is there any declaration of pecuniary interest? Seeing none, we'll move forward. We have adoption of the minutes from the March 6, 2025 meeting. Are there any questions or any pulls from that? All in favor? Sorry, I need a mover for that. Maurice Brenner. Thank you, Councillor Brenner. And a seconder? Thank you. All in favor? Any opposed? John, did you have a question? Can you request to speak again if you have a question, Councillor Neal?
That's all.
Yep. I can hear you. Do you have a question?
No, I was just going to move the minutes.
Okay,
That's all.
Thank you.
But I guess you didn't see the request, so that's all I was doing was moving the minutes. But anyways.
Okay, thank you. So we're going to move on. There are no statutory public meetings. We do have a presentation, 5.1 from Chief Cheeseborough. Where are you? Thank you.
Good morning, Chair and members of the committee. I just wanted to provide a brief update on paramedic services for the year 2024 and provide some insight as to some of the big important issues we have ongoing right now and where we're going within the paramedic services division. Hopefully I can get the buttons right here again. Woohoo, I got it right. All right, so our call volume in 2024, this goes from January through to December, are outlined above. The important one, of course, is our Code 4 responses, which is 81,008, along with our Code 3 responses, 25,807. Those are essentially our emergency responses. Code 1s and 2s are typically very low. Again, for those that don't recall, Code 2s are essentially a book transfer. In other words, somebody has an appointment going from one destination to another, always within hospital to other hospitals, sometimes long-term care facilities. And Code 1s are non-essential transfers that are in a lot of cases are often done now by private agencies that are assisting the hospitals within the areas. Offload delay, well, offload delay in 2024 was a challenge and continues to be a bit of a challenge, but I have some information on that I'll deal with related to the next slide. But our 2024 average for Lake Ridge Health Oshawa was 52 minutes, 25 seconds. Our maximum time was 13 hours and 23 minutes on a single offload, and our 90th percentile was 1 hour, 53 minutes. Ajax Pickering was slightly lower at 47 minutes, 51 seconds. Maximum time of 10 hours and 4 minutes, and our 90th percentile was 1 hour and 39 minutes. So some pretty significant delays. So again, for the 90th percentile, as a reference point, that goal is the hospital will get us out of their facility 90% of the time in less than 1 hour and 53 minutes at Oshawa and less than 1 hour and 39 at Ajax. So very significant times impacting our ability to respond to the community. I broke it down, and I know it's difficult to see on the slide, but you should be able to see it in your deck month by month with respects to specifically Oshawa, because that tended to be our worst performer. And you can see at peak, we had 1,900 hours basically in a single month on offload delay at a single facility. So recognizing that essentially a single ambulance is basically on our 12-hour day car is 2,184 hours a year for a single vehicle. That's like having a 12-hour car in the hospital the entire time for every day for a single month, essentially. So it's a big impact on the overall responses. And again, this could be multiple vehicles in there for 1 hour, 2 hours, 3 hours, et cetera. And that's how it extrapolates into the entire month. So it's pretty significant numbers. When we want to associate a cost to that, again, if I look at Lake Ridge Oshawa alone, it was 14,971 hours in the entire year, using our special event rate at the time, which, as you know, has just recently went up. But that's almost $3 million that it cost the municipality on offload time at that hospital, which is significant. It's a cost we've argued for many years should not be absorbed by the municipality. However, we run into the same challenges lots of other folks do with trying to address this. We're not the only service that struggles with offload delay. Many other services do. I talk to the chiefs in a lot of the other areas. Waterloo specifically, I talk to quite often. They're a similar size service, as is Halton, and they have the same challenges, but not quite to the extreme that we do. On the flip side of that, I have some good news story, because there has to be something at the end of this. We've seen some significant changes lately at Oshawa and Ajax. They have some new management structure in there that is working very closely with our team, our deputies, and the ops soups to see a significant improvement in this. And as of our last report, I had my offload at Oshawa down to under 52 minutes on a consistent basis, which is huge. I mean, realistically, the province allows us 30 minutes. That's kind of what the norm is. In those other slides, I removed that 30-minute window from every number that was quoted there. That 53 minutes includes the 30 minutes. So right now, we're essentially 23 minutes above and beyond what is recognized from the province as acceptable. So I'm quite happy with that number, to be honest. Anything under an hour is fabulous. It gives the crews an opportunity to effectively offload the patient, clean their truck, get it ready to respond to the next vehicle, complete their paperwork, and be able to be back out and respond to the public. So that's a reasonable time, and if we can continue that trend, we'll see a real big impact on our ability to respond to the community. In respects to that, Ajax is even lower. We continue to see big improvements in Ajax, and recently we've struck up a deal with Uxbridge, where a key component called transfer of care, in other words, when the hospital accepts transfer of care for a patient, Uxbridge Hospital is actually timing that and coordinating for us. So we can see some improved numbers there, because these are numbers that have to be reported to the province, and that is utilized to determine vehicle availability. So in the past, there were some discrepancies. The hospital would sometimes say that you've offloaded, yet the patient is still on our bed because they've assumed care and are providing some treatment, even though the patient remains on an ambulance cot. Our position was, we haven't transferred care. If I can't leave your facility and go to another call, we haven't transferred care. So Uxbridge is fabulous, and they come up with this idea themselves on a way to mitigate this piece. So we're seeing positive results there, and hoping we can take that information, extrapolate it to the Lake Ridge Corporation, and use it there as well. CTAS response time in 2024. Our biggest impact is CTAS SCA, so sudden cardiac arrest. Our goal is 60% of the time to be there in 6 minutes or less, and it doesn't necessarily mean RDPS has to be there. It means you have to have a defibrillator at the patient's side within 6 minutes or less. 60% of the time. You see that number is down 45.1%. So we're not meeting our provincial standard on that. And part of that is due to our challenges with offload delay, as well as the demographic within the region. We have, all areas have to be included in that, so I can't create two separate response time standards. I can't create one for the south and one for the north. And as you can well imagine, it takes longer to drive to a call in some of the northern communities simply because of geography. So all of those numbers are extrapolated in that. What we will anticipate seeing is an improvement in that when we come up with a new dispatch system, which I'll address later on. So our other goals, the CTAS 2, 3, 4, and 5 are all well within our requirements. And in fact, I suggest I will probably be bringing a report to this committee and likely council later in the year to make some changes to those numbers as we transition into the new dispatch algorithm, because our CTAS 5s at a 96.9%, that should be significantly lower. We shouldn't be that high. We should actually be lower. Those graphs should almost be flipped to provide you with some context. So a CTAS 5 is a very minor call. So why are we getting there so quickly is part of the issue. We should be able to have those people be able to wait a little bit longer for the ambulance. but we're getting there very quickly. And again, that time limit as a reference point, CTAS 5 is 25 minutes, 75% of the time, and we're well above that on a consistent average. So I'd like to see that number come down, and I will probably make a presentation to see if we can get that number down a little bit and increase that time or decrease that time to make it reflective of what should really be happening, because we believe these numbers don't truly represent the patient's need. They're more of a number to report to the province just on simple response times, and response times don't reflect patient acuity or patient improvement or treatments. Seton Station, well, there it is. I thought I had some really good news to tell everybody. I was really excited about the fact we were going to anticipate occupancy in late April or early May. I was advised late last week that they've run into a little bit of a hiccup with the commissioning of some of the items within the main facility. And I do have another meeting scheduled with Works to determine how that's going to impact us with respects to building warranty and that sort of stuff. So one of the parts that is needed for one of the systems that has failed could be 6 months before we receive that part. So therefore, we wouldn't basically have a certain section within the building that works for us for up to 6 months. So we're trying to determine if it's a critical piece that we can function without it, in which case we could get into that building and start responding from there, or if it's something that will impact our ability to respond from there, in which case we'd have to defer taking the building into our possession. And again, that could push us out as far as October, which really isn't good. I joke and call this my Y3K project because it seems to be going on forever. This goes back to Deputy Moyer started this project with myself several years ago with the support of council and committee. And we're still plugging away on this building. It's a fantastic building inside. I got a tour the other day. Happy to bring anybody out if you have an opportunity. We can still get in the building to look at things, but an absolutely amazing building for the use of paramedic services. Our training center will be there. It's a massive training center compared to what we currently have, and we'll be able to more effectively manage our staff and provide a really robust training opportunity from that facility. Next thing, we have a PCOP overview. So again, some of the key things with this, our PCOP team, it's currently staffed with an advanced care paramedic and a social worker, and they provide critical mental health and addiction outreach services, some navigation stuff, and medical supports to the vulnerable and unsheltered. This is a great partnership we have with our social services team. And really, to be honest, they're the ones that provide a lot of the service navigation and the mental health and addiction stuff. That's not the forte of paramedic services generally. So their team is critical in providing this little bit of support for us. So we work in a team. They go out usually together on a consistent basis to provide that, and we're having real positive response with that. I'm going to present some numbers to you shortly. We do have an ambulance that we're using now. It's a retired ambulance that we essentially transitioned over into the community programs, and I'll have a photo of that in a minute for you. And that allows us to provide wound care to individuals, so that way we're not trying to do this at the side of the road or in adverse weather, that sort of stuff. We can get them into a nice, safe, dry environment and provide the care that these folks need. And likewise, while the paramedic is doing that, generally speaking, the social worker is out interacting with the other people that are in the area, providing some of the other supports that they can provide as well. So it's a great team opportunity. And I do see an opportunity to expand that in the future. We're seeing significant numbers driving up. The MHOP team is integral as well. We have a great partnership with them. They regularly call our PCOP team to come out and do some wound care because that's not their expertise. And likewise, on occasion, we can reach out if we don't have our social worker with us to the MHOP team to come and provide some of the other supports they have the capacity to deal with. We have our mobile clinic going out on a fairly consistent basis now. We've been over to 1635 Dundas, Beaverton Heights, over in Ajax, and we provide some virtual medical assessments, administration, wound care, that sort of stuff is happening in this mobile clinic on a fairly consistent basis as well. Some of the details related to the primary care outreach program, and again, I know this one's a little bit small, but the key thing to note in there is really just our numbers. So when we look at unique clients served. From 2021, we had 312 to 2024, we now have 497. Total interactions went from 1810 to 2769. So these are the combined visits of the PCOP team. So essentially, this number more accurately reflects the interactions for the social worker, simply because they have capacity to track that data better. From a paramedic services perspective, we don't have the capacity within our system to track if I just have a conversation with somebody to determine if they have any sort of need. Once we provide some sort of medical care, that system is tracked in our database. So we can then say, hey, I put a wound dressing on, I provided, an immunization, I provided, Suboxone, any of those sorts of things that are relevant to the PCOP team. So that might explain what, if you look at the numbers, comparing this chart to the next chart here, where there may be a little bit of a difference in the numbers. It's not that we didn't actually see the same number of folks. It's just that the tracking of the data is probably more robust, to be quite honest, on the social services side, because they have that capacity to do that. And we're only obligated to track on the medical side. So that's why we do that sort of piece. So on this slide, you can see our active PCOP clients. So these are ones that are receiving care, essentially. So we went from 218 to 416, so a 91% increase. In-person visits dramatically increased, 149%. And then there's a whole list of the other things that we've dealt with related to that. You can see since the basically the MHOP team came on board, we started tracking that in June of last year. They had 160 outreaches to us to come and provide some medical care to some of those folks that they're dealing with as well. So these are 160 calls that were avoided into the emergency department for the most part, because the PCOP team was able to respond and provide that assistance to the individual, and that avoided sending that person into an emergency department. And to be quite honest, a lot of these client base do not want to go to emergency departments, which exacerbates sometimes their condition. So that's a great opportunity for the PCOP team to get out there, provide this care, keep them out of the emergency department, which is good for both them and for the emergency department. So again, happy to address any of these numbers, after the fact, if anybody wants something specific, some information on, but we're seeing a huge improvement and a big increase on the medical side. So again, that's where we're looking at. We have to determine, are there future opportunities for enhancement on the PCOP team to continue to provide those medical supports. And, we haven't, as of right now, we're not spending a significant amount of time with the PCOP team up in the Beaverton area, and we know our northern communities are struggling as well. So we're hoping that we can enhance this a little bit in the future and allow for the PCOP team to be more robust and cover a greater portion of the municipality at a single point. Right now, they're kind of roaming around, and they do schedule visits up there, but it's very difficult to get a consistent approach when there's such a demand in the south as well. So we're trying to balance that coverage out effectively. This is our CP vehicle. So this is the old ambulance we retired essentially from our side, and we absorbed it into community programs. Again, it doesn't have to meet the requirements under the Act as an ambulance, which is nice for us, because then we can put some more items in the back that are not typically included under the Act for what an ambulance has to have. So the ministry doesn't have any say over this particular vehicle. One of the things we're going to have to look at most likely for next year, because this one's getting a little tired, is likely a replacement for this. A new company has recently been authorized for ambulances in this province. It's called TriStar. It's a Canadian-based company as well, out of the East Coast. I may look at purchasing one of those vehicles as an alternative for primary care, like the PCOP team, simply so we can test the durability of the vehicle. I don't want to buy one, put it into my 911 response fleet right out of the gate, and have failures and that sort of thing, and something that's not really tried and tested in this province. That said, they are very highly used on the East Coast, and they don't tend to have problems, but I want to make sure the citizens and the communities are protected and not impacted by negative responses. And we don't know exactly what the price of this vehicle is going to be yet, but we anticipate it will be cheaper than our current vendor or provider because they're trying to break into the market. We don't know as well if there's going to be any effects specifically on the tariffs. And we also have been advised that the Ford Cutaway, so the front chassis of that ambulance, is disappearing. They're going to stop making those, so we don't know what we're going to end up with as far as vehicles go. Some services have gone to the pickup truck type front end on the ambulances. I personally will try to avoid that at all costs. We tend to hit enough stuff with the smaller trucks. If I get one bigger, I think they probably have a greater opportunity of impacting some stuff. And again, it's not that, you know, this is a staff issue. Everybody knows the conditions they drive in, driving 24/7, adverse conditions, all those sorts of things. And this isn't necessarily us hitting stuff. Sometimes it's people hitting us that impact this. So that's our community response ambulance. And then lo and behold, the other day we took possession back of our bus. So again, thanks to our team at Transit for helping us get this bus. And then we've had it upfitted. So looking at the bus from this location through the front door, you would go in, turn immediately to your left, and you enter one exam room. And then right around where the word, the divider between the word paramedic and services on the wall there, essentially there's another wall there that goes into a second room where the second doors would go into. Those doors will limit view into that area, and both of those areas have full exam sections. And in the back where the community paramedicine program logo is, that's an area where the staff can go sit to have meal breaks or whatever, and they can still manage or do documentation supporting the individuals inside. We have, we're working with some of our other teams to coordinate when we're going to roll this out for its first big event. We had been requested by Lakeridge to utilize this as a potential exam area in the event of failures in their emergency department. And I said, sorry, we're on offload delay. We can't bring in the truck right now. So as of right now, we're not partnering with Lakeridge on that. We're leaving them to fix their own problems. So we're very optimistic that we're going to see some real positive response with this. And again, thanks to our folks at Transit for allowing us to get this this bus. And they're actually allowing us to store it at their facility in Westney as well, which is great for us. So when the bus does roll out for some of its first big events, I'll make sure this committee knows. And if they are in the area and wish to pop by and see it, you're more than welcome to slide by at any time and take a look at it. So that takes me into the community programs. So again, that's our CP program. So we provide 24/7 diagnostic and medical directive treatment and as well as remote patient monitoring. We've started to wind down a little of our remote patient monitoring. We're not seeing the same bang for our buck on the cost. And because our team is so robust, we're starting to be able to not see the big need for that. Our Durham is one of the 6 communities in the entire province that have an LTC plus pilot project. That's been extended. We partnered with some of our LTC homes in the region, Hillsdale, Lakeridge Gardens, Orchardville, and Bon Air. And with that, we can provide some specific treatments within the facility. We can do point-of-care blood work. We can, working with a physician team, we can provide some antibiotics. There's a lot of different things that our team can do. We can do ultrasounds now. And within the first day of doing the ultrasounds, we actually diagnosed an individual with an aortic aneurysm. So they were complaining of some abdominal discomfort. Our team went in, did an ultrasound, discovered there was an aortic aneurysm, and we were able to get that person into treatment and assessment prior to any critical illness or injury happening to the individual. So that's a really great program. The government just announced that they've extended Durham as one of the pilot projects for another year. So we're continuing on with our LTC Plus pilot project. And it speaks volumes, I think, to the team here at Durham for their ability to be selected for that program. The government has come to us on a few separate occasions related to our CP program and asked for presentations at different CP clinics. And they're working closely with our team to kind of set this as the benchmark for provincial CP programs. So again, speaks volumes to our team and to this committee and council for their support of the CP programs. I just want to, yeah, so I mean, I don't need to read the rest. Everybody's capable of reading in there, but that's kind of the key highlights on the community programs. Again, some of the CP LTC stats comparison, you see how we've had some big jumps Client interactions, we went from 6,400 in 2023 to 10,524. That number continues to climb. Telephone calls have increased. Blood draws have increased. Medication admin gone up a little bit. The ultrasounds, because it was new, we only started in September. Again, relatively low, but we're seeing a big climb in that. In addition, I was mentioning that Tuesday of this week, as everybody knows, we had significant ice storms in some of the areas in the northern Durham as well as surrounding areas, Peterborough, Kawartha Lakes, Simcoe. And Kawartha Lakes reached out to us with a challenge they were having with some of their large high-density housing areas that didn't have power. So they reached out and said, can we provide any support? So we sent our CP team up there, and they did 400 door knocks that day, checking on the well-being of individuals, making sure they had blankets, making sure they knew where the warming centers were, making sure that if they needed oxygen, if they were on Home O2, they could get the supplies, coordinating with the Kawartha Lakes team. And I got a big kudos from Chief Johnson out there. She was very appreciative of the support from the region for that, and it was a great opportunity to get our name out there and recognize that we're there to support some of our surrounding municipalities as well. We didn't need them in our area. Our team was very lucky, although we had some pressure points in the north. We were able to support with just our regular responses, so we didn't need that CP team to utilize that area. Simcoe is still having some big challenges right now, and they may be reaching out to us to help manage their warming centers, which they know are going to be in effect until at least Monday at this point. They also had a lightning strike at a facility last night in Simcoe, which caused a fire. So they're dealing with some of that stuff as well. So kudos again to our CP team, and again, thanks to this committee and council for their support of the CP programs. Opioid update. So in 2024, we had 420 suspected opioid-related overdoses. These are documented by our documentation, so this is information that indicates it was a suspected opioid overdose. If an individual calls in and says, I found somebody passed out on my sidewalk, a lot of times the assumption is it's opioid related. We don't make that assumption. We get there, we assess and manage the patients and make our treatments to determine, do we believe it's an opioid overdose? And obviously, if they would respond to naloxone, we could clearly identify that it's an opioid overdose. But we don't always, from a paramedic services, we don't always treat them with naloxone, just to be clear. Sometimes an unconscious breathing patient is much easier to deal with than waking somebody up that is an opioid overdose. They're not always happy to be woken up. So we like to make sure that we manage the people appropriately. So based on our information, that's where we were in 2024. You can see Oshawa was the leader of the pack, 305 suspected opioid overdoses. And I know I use the word suspected on this chart, but I would probably change that to most likely an opioid overdose because they are individuals that either responded to the naloxone if they were given it, or we were able to confirm through the hospital after the fact when we arrived that they did blood work that confirmed it was an opioid overdose. But things we're looking for often could be the pinpoint pupils, but the big thing is the respiratory depression on that. So we're looking for that sort of piece. Because there's other challenges in some of these areas, even like lorazepam or like any of the benzodiazepines can also cause decrease in consciousness. Doesn't necessarily mean it impacts respiratory rate, and obviously is not an opioid overdose. Not saying it's not a problem, I'm just saying it's a different problem. So this is specific to those areas, and again, this is based on our documentation at the time. We know there's more than that because with naloxone in the public, we're also aware that some of these people are being treated and leaving prior to us getting there. So a call could come in for an unresponsive patient in front of a residence, or I'm going to pick on Memorial Park, and our team will respond and the individual is already gone by the time they get there. That's because somebody could have already administered naloxone and they up and left. So we are aware that that does happen as well, but these are actual patient interactions in our case that represent these numbers. That basically wraps up the highlights. Oh, sorry, yes, I forgot about my MPDS. This is probably the most important one for the committee here. So MPDS, which is a medical priority dispatch system. So our dispatch system is changing in May. We're probably in the last quarter of the province to be transitioned over to this new system. Our areas all around us are already on the new system. Lindsay just went live the other day, which dispatches Northumberland, Peterborough, and City of Kawartha Lakes. Simcoe is on Georgian. They're already on MPDS. York is on Georgian. They're already MPDS. Toronto has been MPDS for many, many years. So the areas all around us are already on this new dispatch algorithm. So this algorithm basically is a much more robust platform to determine the request for ambulance or the needs for ambulance. The previous system that they're using right now uses about 40 determinants to determine how they respond to an ambulance. So in other words, they ask you a couple questions and they say, okay, the ambulance is coming, lights and sirens. The new system uses just over 2,400 determinants to evaluate the need for the ambulance. So what that will mean is we anticipate, based on what's happened in the other areas, we will see a reduction in those lights and sirens responses by 30 to 40%, which allows us to more effectively manage our resources. So the simple premise behind MPDS is getting the right resource to the right patient at the right time. So in other words, keeping your resources available for those really true high priority calls. This will have a little bit of a positive impact on our lower tier fire services as well, because in the past, they basically came to a good portion of the Code 4 responses. Now, those Code 4 responses will even be more defined. So the new system uses colors. So red and purple are the most serious, purple being the most serious. So fire will be coming to a good portion of the purple calls. But some of them they would not come to. For example, active labor. We probably don't need the fire department there for somebody in active labor. So they would not be coming to that type of call. In some cases, they had been in the past. So I've worked with all the chiefs to come up with, where they fit in the determinants to make sure it's going to meet what they believe is their demand and their mandate. As an example, they have a different mandate with respects to vehicle collisions, and they come to them anyway. The problem with that is a vehicle collision on the new MPDS algorithm could be a green response, which means we can wait 4 hours to send an ambulance to that call. So if the fire department's there, they're probably not going to want to stand around for 4 hours waiting for an ambulance to get there. So we've had this conversation with our fire services to work with their medical directors to say, okay, if we get there and we're dealing with, spills on the road or that sort of thing, we can manage that and then we can leave because there are no patients needing the paramedic services response. So I wanted to point that out because this is a system, when it's implemented, again, don't get me wrong, it is sending the right resource to the right patient, but I anticipate there will be some people calling to complain to say, where's my ambulance? Or why did it take 2 hours for the ambulance to come to me? Well, that's because these determinants are very robust and get the right resource to the right patient. And the example I like to use is my Whitby station just up the road here, the headquarters. So there's a whole housing development right across the street. I could have an ambulance parked there with, let's say the garage door is open and the people can see it. Somebody across the street calls for a sore toe. They cut their knife or cut their thumb with a knife cutting up some vegetables. That's not a lights and sirens response under the new algorithm. The old algorithm, it would have been a lights and sirens response, and that vehicle from the Whitby base would drive across the street to service it. Now, that vehicle could be serviced with a car from Pickering, as an example. So Pickering could drive over to service that call versus utilizing that car that's at Whitby. But if a cardiac arrest comes in while that car from Pickering is driving over, the car from Whitby will leave and do that. So if I'm looking out my window and I see that ambulance suddenly drive off and not come to my house, I'm probably going to be upset. I'm working with the comms folks to come up with some sort of a program we can get out to the public to make them aware. It's not changing how we come to your call with respects to what we decide as the assignment of the call. It changes that we send the right resource. And that's the big thing that people have to kind of get their heads around. And it hasn't created big problems in other areas. It did create a few phone calls when it first rolled out because people were like, why is the ambulance taking so long to get here? But again, it's based on the priority and that sort of stuff. Niagara's done MPDS for many years as well. And when they changed some of their triage algorithms to further increase the response times for those lower priorities, they had a 72% cancellation rate. So people would call back and say, forget it, I'll drive myself because my sore thumb doesn't need an ambulance after all. I can go to the hospital on my own. So it benefits the community because the patient's not coming in by ambulance to the hospital, waiting to be triaged. They actually come in the way they normally would go in, or they go to an urgent care or that sort of thing. It also helps the service get the right resource to the right patient when they're needed. It allows us to more effectively manage meal breaks, more effectively manage end of shift, overtime. All those things that are a huge benefit to the service will happen with the implementation of MPDS. Along that same lines, we're going to be, we've worked with the province and we've got permission to have a manager from RDPS in the local dispatch center, which is right across the street. So they can more effectively keep an eye on things to make sure that the dispatch system is following our rules, because we set the determinants working with the province. They don't get to pick anymore. It used to be they picked, now we have some input into how that plays out. So again, that should be a big positive for us with effective management of our crews and support of our resources, because they're our resources, not provincial resources, and it's important that they manage those. So that's the big thing with MPDS that's coming down the pipe. And again, I don't have the exact date off the top of my head. May 23rd or 24th rings a bell, and it starts at midnight on that day. That's when they do it. They always implement it at midnight because they don't want to start it at the busiest time of day. They take a little bit of time to blend in. So I'll be on site for the implementation as well as some of my other staff to make sure it goes smoothly, because I can anticipate a couple of hiccups. That's it for RDPS.
Thank you for your presentation. And I believe Mayor Carter has a question for you. Oops, I got rid of Mayor Carter, sorry.
Madam Chair.
Go ahead.
Good morning. Morning. Morning, Chief.
Morning.
Great presentation, by the way. And Councillor Chapman was in my office. He was applauding for the last 20 minutes. So just to let you know, okay? So, Chief, let's start backwards, if you don't mind. 305 suspected overdose calls for the city of Oshawa. The next highest is 57 in Ajax. In your medical profession and your expertise as chief, why? Why such a dramatic difference between Oshawa and the rest of the communities?
Through the chair, I mean, I can't really give you an honest opinion with respects to that. I mean, there are a variety of demographic sort of issues. I mean, I grew up in Oshawa, worked there for the bulk of my career, recognize that there are some unique challenges that Oshawa experiences compared to some of the other municipalities. It tends to be a hub, for lack of a better term. A lot of that client group tends to conglomerate in some of those areas because of some of the supports that are available. And they tend not to leave, as you know. So once they get there, they kind of set up shop, for lack of a better term. So we are seeing the numbers start to creep up a little bit in some of the surrounding areas, such as Ajax, and using some of our current numbers. But I can't really speak to the demographics specifically of that, but that would be my best guess.
Do you have any suggestions how we could see how we can decrease that? Is there any concepts or ideas that you may have to be able to help us see a decrease? Now, we're seeing some numbers that have been decreasing in the first January, February, March, based upon our suspected reporting with fire, which we're not really sure what's going on there because fentanyl is still part of the drug stream. And that seems to be the most dangerous aspect. But is there something different we could do in Oshawa, in your opinion?
Yeah, through the chair. I mean, I guess it's like every area. It's about education and making people aware of the risks and that sort of thing. And I think the health department and other areas are already doing a really good job of making that happen. I just think that the self-awareness is probably increasing, and the true risk identified with fentanyl is probably becoming more I guess that group of clients are becoming more aware of the risks, and they're starting to have a little more controlled use, I guess. What some of my team are reporting back to me is they're seeing the consumption of fentanyl now often done in teams, for lack of a better term. And I hate to say that that's happening, but they're doing it in partners. They're not doing it on their own anymore. So the risk is significantly lowered because they have somebody there to provide some immediate support should they accidentally take too much. So I think that's one thing that's having a positive impact on it, but I don't really have anything other than suggesting that we educate more.
I'm going to go to I think it's slide 10, which is the PCOP 2023-24 program data. Just going to point out one thing. Suboxone administration in 23, that information was not available. 24, there's 12. Can you just let this committee know Suboxone? What is Suboxone, and is it a successful treatment for those that are suffering with severe opiate addiction?
Yeah, so through the chair, so Suboxone essentially is a derivative to help wean off the opioid piece. So it helps with some of the withdrawal symptoms and that sort of thing. And we're having a more positive. People years ago remember the methadone as an example. That was kind of a big item at the time. And what was happening, or what we saw happening with methadone was. Methadone impacted the same receptors in your body that basically it would bind to them to take away the effects of fentanyl, yet still have your brain triggered to think it was working at a high level. Essentially, what we were seeing happening with that was people would be administered their methadone for the entire weekend, and they would combine their methadone with an actual opioid. So they didn't need as much of the opioid to get the same impact because some of the receptors were already bound by some of this methadone. So we're seeing a much more positive, because Suboxone is more controlled, we're seeing a much more positive impact with that. And again, it's too early to predict how it's going to go, but it's a great step in the right direction where we're seeing some of that. And the individual stepping forward to say, hey, I want the help. That's the big thing.
Yeah.
Our team at Social Services is so good with dealing with the addiction stuff and convincing the individual that there are other options. And that's where we're seeing that benefit.
There's another treatment that I don't know if you're able to administer, or it has to be through a hospital, and that is an injection for heavy opiate users that I understand that is a 30-day injection. Ciproco, is it called? I'm not sure the exact name, but I've heard about it. Are you aware of that, Chief?
Through the chair, yes, I'm aware. Right now, that's not in our mandate. There are some other challenges with it. That it won't, right now it's not falling under paramedics to be able to have the ability to administer that. That's why we're trying to work with getting a nurse practitioner on board, because the NP would have some capacity to potentially do that and deal with some of those issues as well.
Thanks, Chief. I appreciate that. A couple more questions just to let you know. Offload delay at Oshawa, Lake Ridge, Oshawa. What investments are needed in that department to be able to help with the off delay? Now, I do understand in your presentation, you said that you're seeing some positive signs in the right direction. That's good. What other additional investments would be a wise investment to be able to get your people back out on the road again?
Through the chair, I guess the biggest impact we're seeing and some of the improvements we're seeing is it's not so much that the emergency department doesn't have the capacity, it's that the emergency department gets plugged, as I've mentioned before. So, especially you look at Friday night, Saturday, there's many patients that get admitted over the weekend. There's no space on the floors to move them. So therefore it gets plugged, and then we come in and there's no beds to put our patients on. So I don't know so much that it's necessarily the issue within the emergency departments. I think the funding needs to be in some other areas of the hospital to allow for a more effective flow through the hospital. And that's what some other areas have done to see that improvement, is increased or improve the flow capacity through the hospital. I remember when I was younger, I was in the hospital for whatever ailment it was, and I was discharged on a weekend. You almost never see discharges happen on a weekend anymore. And that's part of the challenge, right? Saturday morning, I remember my parents coming to pick me up and off I went. But we're not seeing that as often as we used to. And if those discharges were happening on a consistent basis, I think we would see a better flow through the hospital.
My last question goes to, I think, your first slide, which is the call volume for January to December 2024. You said that Code 4, is Code 4 the most serious?
Through the chair, Code 4, as defined by the province, is the most serious. However, as I alluded, that's a bad, it's a bad algorithm they currently use. Because if I call, as an example, if I was playing soccer in July down at Lakeview Park and I roll my ankle, one of the questions they ask is the patient sweaty? If you say yes, it's a Code 4 response. So if I'm playing soccer in July at the lake, I'm probably sweating. So that's why I'm saying it's a very bad algorithm.
Right, and the new kind of system in regards to the identification, that'll make a big difference. The reason why I ask this is because Code 3 and Code 4, and I guess it's Code 8 is what is Code 8, by the way?
Through the chair, Code 8 is standby, so we move an ambulance to another area to cover off.
Oh, okay, all right. So Code 4 and Code 3, is this an indication of the health of our community when you look at the number of these calls? What's the determining factor? Like you look at it, 81,000 calls for Code 4, 25,000, almost 26,000 for Code 3. Two of the most serious. Now, I understand maybe that the change of the description will help us be able to have more reasonable numbers. I think next year it'll be interesting to see. But is this a health indicator, Chief?
Through the chair, I don't necessarily believe that. I think it also reflects the number of people living within a community. Because again, you got to remember some of these could be car accidents. They're not necessarily serious life-threatening injuries. I can break down, for a future request if somebody wants the demographic or the age groups of those calling as well. So I could break it out for you to show you where our heavy areas are and users of the system are. But our CP program has done a great job of mitigating some of that. And 155 King is a great example. We used to do quite a number of Code 4 responses in there. Now with our CP team, we're seeing way, way less Code 4 responses.
Do you know what? You guys are doing an incredible job. You people don't get enough credit, but you guys are doing a fantastic job. Absolutely love the new bus. I just love that. I got the opportunity to meet the gentleman just the other day that did all the interior work, and he showed me some of the interior work. It's just incredible. Do me a favor, pass on our best to your teams because they are doing extraordinary work, and we thank you very much for such a detailed presentation. Wish you the best of the day, sir.
Thank you.
Question for you?
Yeah. Good morning, Chief, and again, thank you for the great work on the weekend and the support you were offered, that you offered to Kawartha Lakes. Your team deserves a big round of applause. Page 15, 420 overdose calls. How many, and you might not have this information, but how many of those calls were individuals that have used that overdose, have been treated on more than one occasion?
Through the chair, you're right. I don't have the number off the top of my head, but I can tell you there are a few on that list. The percentage is probably lower than you think, but some of them are definitely on that. I think last time I ran the number, it was around 7%, which is still a significant number, but it was only around 7%. And I didn't start getting into the multiple uses till I deemed it as 3 or more, because 2, could be a what if, but when we got to 3 or more, much like we got to some of our significant users of the 911 system back in the day, if you called twice, I didn't want to say you were an abuser of the system. So I kind of use the same thing with that number. I can get you specifics further on if you wish.
I think the number is important, and not to offend anyone in the room, but the right to say no is a challenge. So if you have someone that has been treated in this form 4, 5, or 6 times, the challenge to the system is far greater than just here. And that individual needs the support and care to get better, and it's not happening. So they just stay part of the system. Does that information is it broken down to the point where it goes to the province so they can understand, or even the federal government, that sometimes an individual's right to say no is not in the best interest of the individual? I'm sorry, it's maybe a little confusing, but.
No, thank you. Through the chair, I understand your question. Short answer, no, we don't share that information with the province. I mean, there's PHIPAA that still applies. We can't send names across, that sort of stuff. What we do, though, is under that current algorithm, we notify our PCOP or MHOP team and say, hey, you know, here's Troy. We've seen him 3 times in the past little while. Can somebody slide by and maybe have that interaction? Because it's that icebreaker that's sometimes needed just to get them to recognize. Because everybody knows you have to admit there's a problem before there's a problem. And the MHOP and PCOP team do a pretty good job of trying to get those people to step over that lip. But that's right now, we can't report that at specific with names to the province.
But just having paramedics treat an individual is not the answer.
Through the chair, I don't disagree, but it's a bigger challenge. I mean, I can tell you in some communities, they don't even transport opioid overdoses at all. They give them naloxone, they leave, and quite often they're back 45 minutes later when the naloxone's wore off to give them more naloxone. They won't even transport them for a lot of the reasons you mentioned, but then that puts a strain on the paramedic service. So there's a strain somewhere on the system as a result, but they just seem to front load it with the paramedic services versus trying to get to the root of the problem.
And on the same note, do you track individuals that are having severe mental health episodes?
Through the chair, so it's kind of a 2-part answer. Yes, we do, with respects to the code on our documentation, but a lot of that depends on what the documentation that the paramedic puts down as. So if, for example, a mental health challenge is what I would call the #1 issue, but they cut themselves as a result of their mental health struggle, the paramedic may document the cut as the more critical issue, not realizing that it's tied directly to their mental health complaint.
So follow-up question is, how many individuals with mental health issues are users of the system more than once?
Through the chair, we have, I don't know the exact number, but I can tell you there's a few that we see almost on a daily basis.
And that's a vehicle, 2 paramedics, a trip to the hospital, and the end result is, and I'm sorry, the end result is they're back out into a system where there's no support, so they just continue this circle of care, relying upon paramedics and our outreach people and hospital visits, but no chance to get to where they need to be because the right to say no is a problem. And I'm wondering, through the chair, maybe to Dr. Kyle, if that data is not worth collecting to make the argument that the right to say no sometimes is not in the best interest of the individual in any kind of treatment form, other than they're on this path that will eventually end up into a very bad story. I didn't mean to put you on the spot. If you want to think about it, and we can have a sidebar conversation, but I think it's important to understand that the compass of care that we're providing is emergency medicine right at the time, but there needs to be something else so that they don't come back into the system and cause the system to have to grow to meet the needs of individuals that aren't going to get the in-depth care they need to get back onto a path of being being part of society.
So, one, I don't disagree with you, and 2, what's going through my mind is the province has a strategy in place to build a mental health and addiction system. It's called Roadmap to Wellness. And a team within Ontario Health called the Mental Health and Addiction Center for Excellence is developing a system, and a core pillar of that system is, in fact, a data kind of management system. So whether or not information that you've just suggested is captured by that system, I would need to do a bit of a deeper dive to see whether or not that type of data would be collected. What I can commit to do is contact center staff to see whether or not that's on the radar screen and report back, or report to committee offline, if you will, through the appropriate internal communications.
I would be interested in having that conversation. The other part of that conversation is the person that's supplying the poison that causes the problem, and they tend to deal with the same people all the time, and removing that component is also a pathway, but the system is so badly broken. That's me. Nobody needs to answer, but there's got to be a way to fix this for the sake of the individuals, the people that respond to the individuals and put themselves at risk. And hopefully something will happen soon, but you can't fix a problem if there's no way to fix the problem. You know, you admit you have a problem, but then you can't get the care that you need to solve the problem. You can't take the drug dealer off the road that's causing the problem. And when you do take them off the road, the police put them back on. The police don't put them back on the road. The system puts them back on the road. And, you know, when a police officer or a paramedic knows a drug dealer by a first name, there's a problem. But anyways, that's my rant. I'll stop. Thanks, Chief.
Sorry, Councillor Wu, you have a question?
Yes, and good morning, and through the chair, and thank you very much, Chief, for your presentation and even the responses to the questions. I just wanted to make mention too, thank you. I've heard great feedback on the PCOP. The one that I wanted to follow up and mention was the partnership that you have with the Monday Night Project, which is a bi-weekly drop-in that provides safe space for street-based sex workers, survivors of human trafficking, and women at risk. So it's great that Durham Region paramedics are part and parcel of partnering with that. Now, one of the slides, slide 7, you showed Seton Paramedic Response Station. And I did want to ask, and as you may know, and I know you're in the process of looking for a location for the new Bowmanville, I'm going to call it ambulance shed, which is beside Bowmanville Hospital. Now, what I see from the Seton Paramedic Response Station, is that sort of a blueprint of what you plan on future stations?
Through the chair, no, that's a bit of an exception because we've moved our training division there as well. So if you wanted to come up with a high level kind of guideline of what a future station would look like, look towards Sunderland as probably more of the goal of what we're looking to for future stations. We don't need all the additional space that's for training that exists at Seton at any of their other stations.
Well, it is quite impressive. I look forward to the opening, and hopefully it's sooner than October. Now, the community community paramedics or paramedicine. That is what we have at the Enniskillen Station 5 fire station. Is that what's in there?
Yeah, through the chair, that's correct. We have a unit that responds from there as well to service that part of the community. Instead of leaving from Whitby, cuts down drive time if they kind of start their shift there.
Yeah, my question, how is that being utilized?
So through the chair, it's actually fairly well utilized, actually. I don't have specific numbers, but I can get numbers for you and provide you with the number of clients we're servicing out of that location.
Okay. No, great use of that facility. And my last question, and I heard you say that you are an Oshawa boy. And if I can ask, and this is sort of off script, what do you think? How are the Generals going to do against the Steelheads?
Through the chair, go Generals go. I hope they're going to win, but.
Well, I know you're a diehard fan, so thank you very much. Much appreciated. Thank you. Thank you, Chair.
Thank you. Are there any other questions from committee for Chief Cheeseborough? None? Thank you very much for the presentation and the update. It's appreciated.
Thank you.
So next on our agenda is we have Michael Braithwaite, a delegation here today. He's the Chief Executive Officer of Blue Door, as well as Adriana Vandernoot to make this presentation for us.
Yes,
Thank you.
Thank you. Good morning. My name is Adriana Vandernoot. I'm the Director of Quality, Compliance, and Evaluation at Blue Door, and I have Michael Braithwaite with me here, the CEO of Blue Door. So thank you so much for giving us the opportunity to speak with you today about our Housing for All Land Trust. So a little bit about Blue Door. We are the largest emergency housing provider in York Region. We've experienced an incredible amount of growth in the last 5 years. We operate 6 transitional housing sites, including our newest one, which is Beaverton Heights, a 47-unit transitional housing facility for men. We have over 430 emergency housing beds. We also house approximately 400 people per year, so a lot of work happening at Blue Door. We also offer 8 programs through a continuum of housing, health, and employment. That way we make sure that we are offering the people that we serve all the opportunities possible to make sure that they are successful. So what is the Land Trust? Land trusts are an internationally proven vehicle to generate and retain affordable housing. Blue Door recognized the absolute dire need for more affordable housing and wanted to do something innovative that could solve this problem. So after many years of research, connecting with other land trusts, connecting with other community housing partners, we decided that we were the ones that needed to take that big swing, as Michael likes to say, and be the one to launch a land trust. What a land trust does is accumulate housing units, property, land, vacant buildings, and we put them into the trust. That way we can build more affordable housing that will stay deeply affordable in perpetuity. So how the land trust works, the first step, as I mentioned, is acquiring the housing units. So we would accept donations from developers, of units. If somebody's building a 20-unit facility, they might want to donate 2 or 3 units to the land trust to stay deeply affordable. We would accept donations of land and then develop that ourselves along with capital. We've been approached with opportunities of a post office or a school, anything that we can do that we might be able to turn into affordable housing units. We've already started this process ourselves and are developing a 14-stack townhouse unit called Kevin's Place, which will provide transitional housing and emergency housing for the individuals that we serve. The second step is to partner with other social service providers. So it's not just Blue Door. We're not just housing the clients of Blue Door. We are working with the communities that we serve and the other social service agencies to make sure that we are partnering or placing the right people in the right units. So for example, if we were to receive a donation or have a unit that is considered highly accessible, we might approach an organization like Community Living and say, hey, this unit is best suited for the people that you serve. Are you interested in operating this unit? So we would build really strong relationships and collaborate with those other social service agencies. And then lastly, it's to acquire a portfolio of assets. Our goal is to make sure that within the land trust, we have housing units, buildings, houses that would suit everybody, so that we could house youth, we could house families, we could house men, we could have facilities just for LGBT youth like we have, so that we've got the entire continuum of housing options for people. So how will it all connect together and last in perpetuity? We would basically use the equity that we've built by the units, the land, the capital that we've acquired into the land trust to be able to build and build more over time, to continue to add into that land trust. Our goal is in the first 10 years of the land trust launch is to put 200 units into the trust and continue to build on that. The really exciting, innovative part about the land trust is that we would take away a lot of the work and stress and challenges that maybe some of those smaller social service agencies might face. So you might have a small organization that recognizes that they need to find affordable housing for their clients. But buying a property, building a house, developing land that they might have is not feasible for them. There's too much risk, there's too much time, and it's just too intimidating or large of a project to do. So by donating the land, the houses, and having them all available in this portfolio within the land trust means that we do all of the work. We are the asset managers, we are the property managers, we take care of all of the insurance, all of the policies and procedures, all of the legal aspects of it. And now we have this great big portfolio that we can approach the individuals, the other service providers in our community and say, hey, we've got this stuff available. Will that work for you? Or people can come to us. And so it takes away a lot of that pressure. And it also reduces the duplication of services and funding that are spread out across the different social service agencies. So I'm going to pass it over to Michael to wrap us up.
Thank you, Adriana. You know, right now we're at a critical time across our province. If you saw the recent Association of Municipalities of Ontario report, there's 80,000 people experiencing homelessness across Ontario. And if drastic measures aren't taken, that could go up to 300,000 in the next 10 years. The time for Band-Aid measures is over. The Land Trust isn't a Band-Aid measure. It isn't, right? Adriana said we like to take big swings. We do. In baseball, if you hit 1 out of every 3 balls, you're an all-star. And we need to be all-stars on this and take big swings. The Land Trust is that. And so our ask is this of you, is that we work with the region staff, with municipalities to look at options, how we can get buildings into the Land Trust. I know that there's not a lot of levers anymore, but we've seen municipalities like Markham that have negotiated units. Adding floors to a building is pure profit for a developer. If they can give some of those to get that extra floor to the Land Trust, everyone wins. There's a way to still make money building, but also do social good. So why not take both of those wins? There's a way to, as the town of Aurora has done, where they put out to people with proposals coming forward to say, we would very much like you to help us meet our affordable housing goals by working with Blue Door and this Land Trust to see what you can do. And they understand and read between the lines. That is the right thing to do as well. It all starts with land. We were able to raise recently $9 million to do the 14 stacked townhomes that Adriana talked about in Newmarket because we own that land. Small building, big piece of land, irresponsible of Blue Door to not do anything, take action. So we've knocked that down. In 18 months, we'll have 14 all affordable units, deeply affordable. Now, with bigger projects, bigger pieces of land, there'll be a mix. Mixed housing is the best way to go, as of course the team here in Durham is well aware, and they're experts, right? But those are mixed communities. If we can have market that pay for the deeply affordable, and we have buildings that forever are dignified and beautiful, like Beaverton Heights, like the region of Durham has built, that's the way forward. So we're asking you as a committee to recommend or make the motion to direct the staff to continue to work with us on ideas on how we can bring this trust alive to support our most vulnerable and create that housing in perpetuity. And the idea too is to build. As we get more assets into the trust, you have equity in the trust where you can buy more housing, maybe sell some of the single units to buy more housing and continue to build on that. A little different from regional housing in a sense, or you know, and we're not in competition. The difference is we have different levers to pull because we can fundraise dollars to do that as well as government dollars as well. And so we want to continue to work with you on how we build up this trust so we can build up the housing we need and take those drastic measures to make sure our vulnerable people are well taken care of. And that's what we have today. I would open it up to questions if you have any.
Thank you. Are there any questions from committee? Councillor Brenner, thank you.
Thank you, Madam Chair. Through you to the delegation. Do you have the ability to work direct with developers that may in fact be building intensification, but could benefit from the whole idea of providing the type of housing that you're talking about?
Through you, Madam Chair, absolutely. I think that's a big part of what we're going to do here is work with private developers so we can both meet their needs, but they can also do some social good as well. So we'd love to do that. And we've had, right now we're working in Newmarket, the actual town is going to provide the land, but then we'll work with Daniels, who's done a lot of deeply affordable housing mixes to develop that and make it a reality.
Perhaps we could connect then offline. We have a huge intensification program going on within the city of Pickering, as an example. And the discussion comes up over and over again in proposals and concepts. What are you providing in terms of affordable housing? And usually we don't get a lot of clarity from the applicants. So perhaps if, we can connect offline and then maybe set up a discussion and see how things can roll out in terms of somewhere in the city of Pickering where we badly need more affordable housing.
That would be wonderful. Yeah, would welcome that.
Thank you.
Mayor Carter, you have a question?
Thank you, Madam Chair. Michael, always a pleasure. You know that. Pleasure looking sharp today, buddy. You're not even going to respond to that at all, are you? Michael, I want to just talk just for a minute. I know the work you do, but I'm getting more and more when we're looking at these projects to make sure that also supportive services are available on site. That seems to be a key in regards to the success, longevity of success of individuals. Is that something that especially our committee should really take into consideration? And have you worked with certain organizations that really do it well?
Through you, Madam Chair. The type of housing that I think we're looking at for the trust is semi-independent, supportive housing. And part of when we work, as Adriana mentioned, it might be some Blue Door clients through Beaverton or others, but also all these other nonprofits. The idea is they become our tenant. The clients would be occupants of that building. So there's a little more flex if things aren't going well. But the two things that are must when we're leasing it to a nonprofit, it would be that A, they can't charge more than we're charging them, deeply affordable, but also they provide the wraparound. And we'll also continue to work with the region to see what wraparound supports can be there. We make mistakes at time, but believe it or not, sometimes, and we put people in what we think can handle or are ready for semi-independent housing, and they're not. And so then it's up to us to work with our clients or work with that organization to find alternative housing where they get the supports they need. Because the idea behind all of this is you need to be a good neighbor. And if you're a good neighbor for a while, things go sideways really fast and people will not continue to welcome new developments from the trust and new housing developments, of course. I hope that answers the question.
Yeah, I mean, we're working with a couple developers that are well versed in affordable housing, RGI housing, and they're bringing forward concepts and ideas about making sure that we have certain services on site, such as loft community services, and make sure that they're there. But your point that you just made, that I think is a really important thing, is people that are equipped or prepared, ready to be able to move into these units is another component that has to be taken into consideration. I know that we've had circumstances where we've placed individuals into a housing unit that are not able because of the life skill gap and that they need additional services. And I think that sometimes takes us back. So I'm glad that we've had this conversation. I think it's an important conversation, especially with our local housing authority and our nonprofit housing authority through the region of Durham. I think it's a really important component in regards to the success, because this is about success of the individual and making sure that the longevity of a safe, affordable, supportive environment for the success of their well-being, of health and well-being. So, Michael, thank you. It's always a pleasure. Do me a favor, keep up the great work. You're doing some fantastic work, and you're the right spokesperson and champion for this. So it's really good to have you here in Durham Region.
Thank you, Mayor Carter. And just lastly, to your point, too, I think we absolutely need more emergency housing or shelter. We like to call it housing if it's just, even if it's one day at someone's home. But there's a lot of people, I think, in emergency housing that don't necessarily need 24/7 support. It's very expensive for them to have that. And if we could create other housing options where they just need a little support or a break on the rent, we're going to free up those spaces in emergency for these individuals who can't get to it now because we're full up. So hopefully that's what we need to do. The more we create in the community for people who are ready, the more robust system we'll have.
Thank you. So, Mr. Braithwaite, would you be agreeable to perhaps attending our committee of the whole of council next Wednesday, that's the 9th? And then we can think about putting forward that motion that you spoke to.
Absolutely.
I think it's sometime more helpful if we could speak to everybody and educate them about the issues. So I'll give you that motion. Thank you. All in favor? Any opposed? It's carried. Thank you very much. Appreciate your presentation.
Thank you.
So moving forward, there is no correspondence, but we do have a health report. So it's the nomination. It's for a nomination for Councillor Liz Roy for election to the Alpha Board of Directors for a 2-year term to represent the Central East region. Can I move it? All in favor? Got a seconder? Any opposed? It's carried. Thank you very much. And moving down, let's see. Okay. We have a previous report, 3.1. Where am I? Nope, sorry. It's got me screwed up. Okay. We have no correspondence for health or for social services, and there are no reports for social services either. I think that's it. Our next meeting will be on Thursday, May the 8th. Does anybody have any other business they want to speak to before we adjourn? Okay, motion to adjourn, seconder. All in favor? Thank you. Thanks for coming today.